morning. Dr. Bimsar Sennaika, consultant neurologist, Institute of Neurology, National Hospital, Sri Lanka. The orator of Dr. P. Sivasubramanium, Oration. Past presidents, members of the council, fellows and members of the college, invited speakers, distinguished guests, ladies and gentlemen. The prestigious Dr. P. Sivasubramanium Oration has been a tradition at the annual scientific sessions of the College of Ophthalmologists of Sri Lanka since its inception. Dr. P. Sivasubramaniam is the founder president of the College of Ophthalmologists of Sri Lanka, then known as the Ophthalmological Society of Ceylon. The first Dr. P. Sivasubramaniam Oration was delivered in the year 2003 by Dr. Reggie Seaman. To date, distinguished personnel in the field of ophthalmology in Sri Lanka have delivered this oration. The orator for this year is Dr. Bimsar Sennaika. I am indeed honored and privileged to introduce Dr. Bimsar Sennaika, MBBS, MD Colombo, FRCP London, FCCP, Consultant Neurologist, Institute of Neurology, National Hospital of Sri Lanka, Colombo. Dr. Bimsar Sennaika is currently the Senior Consultant Neurologist at the Institute of Neurology, National Hospital of Sri Lanka. He obtained his MBBS in 1991 with distinctions and honors from the North Colombo Medical College. He completed his postgraduate doctorate in medicine from the University of Colombo in 1997 and subsequently he trained in neurology at the Institute of Neurology, National Hospital, Sri Lanka. Having proceeded to the United Kingdom for further training, he worked at Queen's Hospital Essex Neurosciences Centre and at the National Trauma Foundation in the UK. He also worked briefly as a consultant neurologist for NHS UK. He obtained the membership of Royal College of Physicians, London, that's MRCP, in 2001, and the fellowship, the Royal College of Physicians, London, FRCP, in 2009. He is also a long-standing member of the American Academy of Neurology, AN. He obtained his board certification as a specialist neurophysician from Postgraduate Institute of Medicine, University of Colombo in the year 2000, and thus has been a board certified neurologist for almost 25 years. Dr. Sennaika is currently the most senior neurologist in the Department of Health in Sri Lanka and was 7th neurologist to be appointed to the Institute of Neurology at the National Hospital, Sri Lanka, since its inception in 1959. He is also honorary senior lecturer to the Department of Clinical Medicine, University of Colombo since 2016. Dr. Sennaika is currently the chairperson of the Specialty Board in Neurology at the Postgraduate Institute of Medicine, University of Colombo. He is also a member of the Specialty Board in Clinical Genetics at the PGIM and is a neurology trainer in adult clinical genetics. He played a pivotal role in the creation of the Association of Sri Lankan Neurologists in 2006 and was its founder joint secretary. He went on to become the president of the ASN in 2012. He is also Sri Lankan national representative and national delegate at the World Federation of Neurology and the national representative in the Multiple Sclerosis International Federation. Dr. Sennaika is the founder president of the Sri Lankan Committee on Treatment and Research in Multiple Sclerosis and Related Disorders, which is modeled after similar regional and national committees disseminating knowledge related to disorders such as multiple sclerosis, neuromyelitica optica, inflammatory optic neuropathy. Dr. Sennaika is also the founder president of the Movement Disorder Society of Sri Lanka, which is an affiliated member of Society of International Parkinson's and Movement Disorder Society Asia Oceanic section. He is actively involved in both undergraduate and postgraduate teaching in neurology and also the examinate undergraduate and postgraduate examinations. He has trained more than 25 young Sri Lankan specialist neurologist over these years. He is also a trainer and examiner in neuro-ophthalmology. In 2012, he launched the first dedicated neurology journal in Sri Lanka, the Sri Lanka Journal of Neurology. Dr. Senak has published widely many reputed international journals, including the Lancet, International Stroke Journal, JNNP, BMG, and is a principal lead investigator in many multi-centered international clinical trials in stroke, movement disorders, demyelinating disorders, and others. He is also a reviewer in many journals, including the BMJ group. His work in demyelination and stroke has been cited multiple times in various publications, including international diagnostic criteria. He, along with his team at the National Hospital, conducted a collaborative AQP4 and MOG zero prevalence study with the Mayo Clinic USA on all patients with central nervous system demyelinating disorders for last 10 years from 2013 to 2023. This landmark collaboration with the Neuroimmunology Department at the Mayo Clinic USA was the first such research Mayo has undertaken outside USA. Central nervous system inflammatory demyelinating disorders and movement disorders are his area of special interest. Now I have the honor of inviting Dr. Bimsar Senak to accept the medal awarded to the college orator by the college and deliver the P. Sivasubramanium Oration on optic neuritis in the era of biomarkers, the Sri Lankan experience.
Thank you very much. Good morning, distinguished guests, ladies and gentlemen. It's my singular honor and privilege to be invited by the Sri Lanka College of Ophthalmologists to deliver this year's prestigious Dr. Ponnaiah Sivasubramaniam Oration. And I'm also incredibly grateful to the President and the Council of the College for giving me this opportunity to present some of the work we have been doing over the last decade in this field of neurology with the collaboration, as mentioned, with Mayo Clinic USA. Dr. Ponnaiah Sivasubramaniam, DO, MS, FRCS, FRC Ophthalmology, FCS, was born in 1916 and had his early education at St. Patrick's College, Jaffna, and St. Joseph's College, Colombo. Then he went on to graduate from the Ceylon Medical College with first-class honors. And he was the first Sri Lankan ophthalmologist to obtain FRCS in 1950. He served as ophthalmologist for several decades at the National Eye Hospital, and he was the founder member and later president of the Ophthalmological Society of Ceylon. And he was the president of the Sri Lanka Medical Association in 1976 and the founder president of the College of Ophthalmologists of Sri Lanka in 1992. He had numerous publications in national and international journals, including the British Ophthalmologist Journal, American Ophthalmology Journals, and Archives of Ophthalmology, Oriental Archives of Ophthalmology, etc. Dr. Ponnaiah Sivasubramaniam was bestowed with the Jose Rizal Award in 1974 for the outstanding contribution to ophthalmology in the Asia-Pacific region and led the National Plan for Prevention of Blindness in Sri Lanka in 1990 with a landmark survey on blindness. And he was instrumental in developing the logo, which we see here, of the College of Ophthalmologists in Sri Lanka, and wrote a book for the medical students, textbook in ophthalmology. He was a man of incredible wisdom and innovation and integrity. He pioneered keratoplasty surgery in Sri Lanka, inspired many colleagues and students and stimulated them throughout his career. The possible first accurate, insightful description of transient bilateral visual loss due to bilateral simultaneous optic neuritis actually comes from one of Charles Dickens's novels. He published this novel, Bleak House, between 1852 to 1853 in 20 episodes. And the main fictitious character in this is a lady from Bleak House called Esther Summerson, who had transient bilateral visual loss. Bilateral simultaneous optic neuritis may have been a possibility in Esther. So remarkably, Dickens goes on to say that he observes many clinical features as prodromal phase, nadir, gradual recovery over weeks, glare disability, reduced contrast sensitivity, possible Uthoff phenomenon, and visual fading in Esther. So the accuracy of this description by Charles Dickens led to British neurologist Lord Russell Brain quoting that it would credit a trained physician. Remarkably, Dickens observed all this even before MS was first described by John Martin Charcot, the father of modern neurology, in 1868. So Charcot went on to describe this condition as a new neurological disease, and this is his handwritten manuscript and sent off a plaque of a pathological specimen in a patient that he did an autopsy on. The clinical diagnosis and the natural history of optic neuritis was established in the late 1880s by ophthalmologists Von Greve and Nettleship. So the optic nerve is the communication cable between the eye and the brain, and it connects the retina to the visual cortex. Technically, it's a myelinated tract of the central nervous system rather than a classical peripheral nervous system nerve. It derives from the outpouching of the diencephalon from the optic stalks during the embryonic development. Hence, the fibers of the optic nerve are covered with myelin produced by the oligodendrocytes rather than the Schwann cells. And it is ensheathed in all three meningeal layers. So it's a very interesting thing that the optic nerve actually is like a tract of the brain rather than a peripheral nerve. And the unmyelinated axons of the retinal ganglion cells converge like the spokes of a wheel as depicted there in that picture to form the optic nerve. The axons of the optic nerve becomes myelinated immediately posterior to the optic nerve head. Then the optic nerve leaves the optic canal, through that optic canal, through the sphenoid bone, continues to form the optic chiasm, and the track follows that, and the visual information is conducted to the final destination in the occipital cortex, and the optic neuritis usually affects the myelinated nerve fibers from the optic disc to the optic chiasm. So optic neuritis is the inflammation of the optic nerve. It is the commonest cause of optic neuropathy in the young, and the insult could be autoimmune, infectious, or inflammatory. For the purpose of this talk, we will be concentrating on autoimmune inflammation of the optic nerve. The clinical spectrum, essentially, it's a clinical diagnosis. Subacute monocular rapid loss of vision reaching a nadir in about 3 to 7 days with a visual acuity of 60 initially, which returns to normal within about a month. Diminished color perception, decreased acuity, dim light often can persist. And there can be photopsia, potential for long-term visual defects, and even blindness is there after optic neuritis. Pain is the other classical feature with typical optic neuritis. Pain with eye movements precedes the visual loss in approximately 90% of the patients, so therefore they can be mistakenly diagnosed initially as migraine. Pain is more common when the orbital segment of the nerve is affected, and also it can last for about 3 to 5 days usually, and if the pain lasts for longer, more than 7 days, it is unlikely that the patient has optic neuritis. The other highly characteristic feature, of course, is the decreased color vision and the contrast sensitivity. And the visual field defects can be many. There's no set visual field defect that you might see with them. And the fundal examination usually we might see in a typical case mild swelling in about 1/3 of the patients, but most of the patients will have a normal fundus. And almost all cases of optic neuritis, there is a RAPD present, afferent pupillary defect, especially if it's unilateral. And in MS-related optic neuritis, only 3% of them will go on to get severe visual loss, 20/200 vision, which is the legally blind level. So the fundoscopic examination is crucial in these patients. Mild nerve fiber layer swelling, greatest at the temporal portion of the disc, the black arrow, which is depicted there, without hemorrhages or cottonwool spots. As mentioned earlier, fundal examination reveals only mild disc swelling in about 1/3 of the patients, but the majority will have a normal fundus. The baseline fundal examination is enormously important. It has implications in the diagnosis and the treatment as well as the prognosis. In atypical cases, like in this one, there's bilateral involvement, disc swelling, grade 3 optic disc, edema with peripapillary hemorrhages. So this is a case of MOG-associated optic neuritis, which is an atypical one. MR imaging also plays a vital role in the initial diagnosis of these patients. The right optic neuritis in this case of MRI axial views, the image of choice is T1 fat suppressed images. As you can see on the right-hand side, there is an obvious hyperintensity of the optic nerve, which is with the black arrow there. And post-gadolinium enhancement also is seen in these patients, is fat saturation in patients with right optic nerve, swelling and enhancement of the right optic nerve, as you can see. And contrast enhancement of the nerve is best seen in fat-suppressed T1 coronal images. So you've got to do fat-suppressed images to get a proper idea about optic neuritis in patients when we do the imaging. And also, in more than 90% of these patients, if you do the MR imaging, the orbit, within 20 days of visual loss, you will see abnormalities. So it's an important tool in the diagnosis process to do an orbital MRI, not a brain MRI, a dedicated orbital MRI, to look for enhancement of the optic nerve with a T1 fat suppressed image. So this is the left optic neuritis coronal view. GAD enhancement, again, on the left optic nerve is seen. Retrobulbar intraorbital segment of the optic nerve appears swollen there. T2 signal persists, maybe even permanently. And in MS, the segment of the optic nerve involvement is usually short, unilateral, and confined to the optic nerve itself. So in this case, the atypical form, again, in a MOG antibody-associated case, there's obviously bilaterally the optic nerves are involved, and they are longitudinally extensive lesions. In 80% of these cases, the lesion can be longitudinally extensive. And also there is perineural enhancement. It's not confined to the nerve itself. There is perineural enhancement as well. So in cases of bilateral optic neuritis, in MOG-associated disease, bilateral optic neuritis is more common in NMO and MOG-associated disease. Involvement of the chiasm is generally indicative of aquaporin 4 associated disease. Longitudinally extensive lesions in the retrobulbar portion of the optic nerve are commonly associated with MOG and NMO-SD. And perineural optic nerve enhancement, as you can see in this case, is frequently seen with MOG antibody-associated optic neuritis. So MR images are T1 weighted with gadolinium enhancement. So the MR imaging of the orbit, dedicated MRI imaging of the orbit, plays a vital role in addition to the clinical evaluation in diagnosing these different types of optic neuritis. So in this case of aquaporin 4 related optic neuritis, two patients. A, you see the dense gadolinium enhancement in the posterior portion of the right optic nerve. And in the other case, B, you see bilateral involvement of the optic nerves going up to the chiasm. The chiasmal involvement usually is seen in patients with aquaporin 4. The other interesting tool that we seem to be getting used to now is the, OCT, where the ophthalmologists and the neurologists come together. It is like the window to the brain, optical coherence tomography. So this is now being increasingly used in evaluating these patients. Optical coherence tomography is a non-invasive imaging method. It takes cross-sectional pictures of the retina and its distinctive layers, and it allows mapping and measuring of the thickness of these layers, and specific diagnosis can be made based on the findings on these. And OCT is used to evaluate disorders of the optic nerve, which changes in the fibers and of the optic nerve, and it can also quantify the atrophy of the optic nerve. So it's a reliable structural marker, complementing, of course, the clinical evaluation. Measurement of the retinal nerve fiber layer thickness, or RNFL, confirms and quantifies the temporal nerve fiber layer thinning. Thickness measurement is shown in the black line there, with normal range depicted in the green zone, borderline in the yellow zone, and of course the red zone showing the abnormally low involvement. The following optic neuritis, the optic nerve demonstrates pallor, which is probably due to axonal loss following the demyelination. So in this patient with MOGAD, or MOG antibody-related optic neuritis, the images A1, A2 on the left side shows acute optic neuritis, in which case the retinal nerve fiber layer appears thickened in the acute stage with a normal ganglion cell layer. But as we go on, after 1 year, you can see on the right-hand side, the B1 and B2, the thinning of the retinal nerve fiber layer significantly. And there is visual recovery in this patient. However, in spite of that, there is thinning of the layers. So in this patient with OCT with a patient with MS, initially there is again thickness stabilizes around 58.1 microns, and as you go on with relapses, the RNFL loss is greater, so you can see there's significant loss, and you can monitor these patients using OCT sometimes. Also in aquaporin 4, similar changes can be seen in these patients with significant optic atrophy in the right eye, in this case, with this pallor. So optic neuritis is actually a neurological emergency. The acute visual loss, initial treatment is somewhat similar in all cases, whatever the underlying cause is. So first line we use IV methylprednisolone, IV rituximab, IVIG. However, depending on the response, if the response is poor, we go on to use plasma exchange. And the interval between the steroids and the plasma exchange is debatable. Now it is generally thought that earlier the better to go for plasma exchange if there is limited response to the other first-line treatment. So that's what we do at the Institute of Neurology. Most of our patients undergo plasma exchange fairly early. So it is important to determine the underlying cause with clinical exam, MR imaging, OCT, serology, and so on. And the disease-modifying drugs should be started according to the underlying diagnosis, because some drugs which are used for MS, for example, can be harmful to the other conditions. So the patients have to be followed up regularly, and of course, they have to be treated throughout that period. The length of treatment, of course, depends on the type of diagnosis, underlying diagnosis. And sometimes we may find it difficult to find underlying diagnosis in these cases. So, however, accurate early diagnosis is of vital importance to initiate long-term treatment and to prevent further deterioration and further episodes in order to ensure there's good vision and it can be vision saving. So we could say time is vision, we say time is brain in stroke management. So it's time is vision here, earlier the better. Optic neuritis in the pre-biomarker era was, of course, always multiple sclerosis. So this is a typical case like that, a 28-year-old woman presenting with right eye pain, headache, blurred vision, 20/40 vision, abnormal visual fields, and left eye is normal. So the MRI showed some enhancement in the right optic nerve, delayed VP, and the patient was treated with methylprednisolone. After a few weeks, the patient's vision is restored, and patient is okay. However, typical optic neuritis has a very strong association with MS. So at presentation, it might be 15 to 25% of MS patients having optic neuritis, but at some point in the disease, they get about 65% of them will have optic neuritis. So likelihood of isolated optic neuritis progressing to MS is best predicted with brain MRI at the time of the diagnosis. So it is very important that all patients who presents with the first episode of optic neuritis get properly evaluated neurologically to ensure that there is nothing underlying which can progress further and cause more damage. So as in this case, the MRI brain, soon after one episode, shows lesions, periventricular lesions, which are very suggestive, and black holes in T1, which are suggestive of multiple sclerosis, but he has only had one episode of optic neuritis. So using the revised McDonald criteria of 2017, even with one episode of optic neuritis, we could make a diagnosis of MS using the MRI and the oligoclonal bands in the CSF as a surrogate. So we just need one episode to diagnose multiple sclerosis and start treatment for prevention of further events and further neurology. It could be more than just optic neuritis, the next event. So that is what is important about this, to make a quick diagnosis and go on to start treatment. The ONTT trial was done in the pre-biomarker era, starting in 1988. This was a landmark trial. I'm sure all the ophthalmologists are fully aware of this trial. Supported by the National Eye Institute of USA, carried out at 15 US centers. They recruited patients from 1988 to 1991, 3 years. At 15 centers, they recruited about 457 patients and 3 arms, placebo arm, IV methylprednisolone and oral prednisolone. And they found that this was designed actually to look for treatment responses to patients with optic neuritis. Then it was followed up further for a further 15 years, from 1992 to 2007, to see the long-term effects. And these are the patients who were recruited for this trial, patients with unilateral optic neuritis between 18 to 45, with no previous history of optic neuritis in the affected eye, no disease other than MS, and no previous treatment with steroids. So these patients were primarily females, 77%, and most of them were white Caucasian females. And they found that the IV methylprednisolone followed by oral steroids was the most effective way of treating them. And also this treatment, interestingly, initially, there was a temporary reduction in developing a second demyelinating event when you treat them that way. So oral steroids did not have any place. IV steroids followed by oral steroids definitely had response, good response, hastening the initial recovery. So the risk of developing MS after a person gets an optic neuritis episode is about 50%. If you follow them up for 15 years, after a single episode of optic neuritis, there's a 50% chance that this person can develop MS in 15 years. And if there were brain lesions, that goes up to 75%. And if there are no brain lesions, perhaps it's much less, 25%. So the presence of enhanced intuitive-weighted brain MRI lesions make the diagnosis, as I said, can be done earlier because it helps to get the criteria for dissemination in space and dissemination in time as well, with the presence of oligoclonal bands in the CSF, which indicates intrathecal production of immunoglobulin. So now, all optic neuritis patients are not MS anymore. Inflammatory demyelinating disorders of the central nervous system has a long list now. In addition to MS, there's aquaporin 4, NMOSD, MOG-associated disorders, isolated optic neuritis, ADEM, MDEM, CRYON, RYON, and many, many. So because of that, now if one gets optic neuritis, there's just more than MS. So 2 novel glial antibodies discovered over the last 15 to 20 years enable recognition of patient subsets, antigen-specific CNS inflammatory demyelinating disorders manifesting with optic neuritis. So with live transfected cell-based assays, myelin oligodendrocyte glycoprotein has emerged as a reproducible marker. And also aquaporin 4, a biomarker, was discovered in 2004 in a subset of patients with optic neuritis, which is a clinically distinct disease from multiple sclerosis. Going back in history, Eugene Devic, a French neurologist from Lyon, in 1894 presented a single case of a 45-year-old woman who came to him with visual impairment, bilateral, and then 2 months later developed transverse myelitis and then died. So he concluded that it was a monophasic illness. So autopsy done by Devic showed there was severe demyelination and necrosis extending to about 4 to 5 centimeters in the lower thoracic and lumbar spinal cord. And there was demyelination in the optic nerves. The gross examination of the brain was unrevealing. So Devic emphasized the fact that the pathology of the spinal cord and the optic nerves were the same. So Devic's disease described the spinal cord optic nerves involvement, which is resembling multiple sclerosis. And the pathological similarity was also emphasized by Devic, so he called it neuromyelitis optica, and followed by Devic, Gall, his PhD student, went on to review 16 further cases, similar cases which existed at the time in Europe, and labeled them as a variant of MS. So this disease evolved over the next 110 years from Eugene Devic to van der Lennen. Van der Lennen is, of course, the professor of neurology and immunology at Mayo Clinic, who is the founder founder head of the Mayo Neuroimmunology Research Lab. And this is the groundbreaking discovery in 2004, which was published in The Lancet, the serum antibody marker, which was aquaporin 4, novel pathogenic antibody, was found in a subset of patients in this group by Dr. van der Lennen and Sean Pittock, Bingachak, and the others. So this was a landmark paper because this actually, this was a discovery of a new disease. So this is completely different from multiple sclerosis. All these patients were previously labeled and lumped together as multiple sclerosis, now found to be having a totally different disease, and treatment used for multiple sclerosis made them worse. So this is a very specific biomarker because in Japan, there were patients who were having optic nerve involvement in spinal cord. They were called opticospinal MS. And after the discovery of aquaporin 4, this entity called opticospinal MS was dropped, and that diagnosis was discontinued. So this is a landmark discovery. The antigen was found a year later at the astrocyte food processors near the blood-brain barrier. And the antibody test enabled accurate diagnosis and treatment of MS and NMO, because NMO was misdiagnosed as MS very frequently. And 1/3 of these patients, as you can see, it's 99% specific. is a pathogenic antibody. However, the sensitivity is about 70 to 75%. So about 1/3 of the seronegatives had a second antibody called MOG IgG. So the testing done at Mayo Clinic using live cell-based assays, method called fluorescent activated cell sorting, FACS assays, are done on these patients, which is the most sensitive, specific way of testing for aquaporin 4. So the target antigen was the aquaporin 4 was found the most abundant water channel protein in the CNS. Is highly concentrated in the spinal cord, gray matter, periaqueductal, periventricular regions, astrocytes, food processors at blood-brain barrier. These are the primary targets. And aquaporin 4 antibody plays a direct role in the pathogenesis of the disease. And area postrema is a preferential target of the aquaporin 4, so sometimes the patients can come with intractable nausea and vomiting and hiccups without any other thing, going on for months and months, wrongly diagnosed, sometimes as psychogenic, ECT is done, and so on. But with methylprednisolone, the patients will immediately recover. So the term NMOSD was coined by Mayo Clinic in 2007 to acknowledge that some aquaporin 4 positives have recurrent transverse myelitis and without optic neuritis, and vice versa. So they don't fulfill the 2006, the so-called Wingchuk criteria, so they went on to produce the new criteria, 2015, the neuromyelitis optica spectrum disorder diagnostic criteria, which no longer requires to identify these both myelitis and optic neuritis in the same patient. If the serum tests are positive, there are 6 core clinical features which we use in these patients to make a diagnosis based on this diagnostic criteria. In a classic case of aquaporin 4 IgG and MOSD, which is a distinct disorder, as you can see, there's a long lesion myelitis, which is seen in about 86% of the cases. And sometimes you might see short segmental lesions in about 14%. And of course, the area postrema that's in the medulla, you can see those lesions which are responsible for the area postrema syndrome. And of course, there can be optic nerve lesions, which involves, as depicted there, involves the chiasm, the optic nerve. And in addition, there are brain lesions. So in aquaporin 4 disease, more than 60% of them have brain lesions in different parts of the brain, as you can see. So there's a whole list of areas like thalamic, hypothalamic, midbrain, periaqueductal, callosal regions. So this is leading to more confusion, because if you see brain lesions, optic neuritis, you think, well, it could be multiple sclerosis, but it could be something else. And about 20% of the NMOSDs are seronegative for aquaporin 4, and in them you see the other antibody, which we call the MOG antibody, myelin oligodendrocyte glycoprotein, a protein on the surface of the oligodendrocytes, was considered as a potential antibody target in multiple sclerosis, but MOG is a component in the CNS myelin and expressed in the outermost lamella of the myelin sheath, and it is exclusively expressed in the CNS. And MOG IgG causes another distinct, well-defined inflammatory disease of the CNS with optic neuritis, which is different from aquaporin 4 disease, different from MS as well. So MOG, of course, has different phenotypes. It's heterogeneous phenotypically. Optic neuritis, ADEM, transverse myelitis, and other central nervous system manifestations. So human MOG has 139 amino acids. They are responsible and contributes to the maintenance of myelin, but it's only a small fraction of the myelin sheath, 0.5%, but it's highly immunogenic, stimulating a T cell as well as a B cell response. And MOG has a potential for pathogenic role, and at present at disease onset, it can remain so, and it can depend, the titers can depend on the disease activity and so on. So in 2007, again, a breakthrough occurred, and this was considered to be a separate disease. And further, new generation cell-based assays developed at Mayo Clinic made it clear the phenotype of MOG clearer. So testing of the MOG antibodies are also done with live cell-based assays, and they have a clear positive MOG positivity if the titers are more than 1 in 100. Between 1 in 100 to 1 in 10, they are low positive, and if they are found, they are highly specific. It could be a biomarker for MOG-associated disorder. False positives can be there in patients with very low titers, can be there in MS patients very rarely. So as I said, there is a heterogeneity in the phenotypes, not only optic neuritis, myelitis, ADEM, encephalitis with MOG disease. So MOG optic neuritis, which is the commonest presentation, it recurs commonly, and 80% of the patients can have 2 or more episodes. Visual loss is typically central and severe, and optic disc edema is found in about 86% of these patients, and it is bilateral in over 50% of the patients. And recovery from MOG is generally good, with only a small percentage of people having significant visual loss after long-term follow-up. Residual optic disc pallor is common in MOGADs, and also some of them can exhibit a steroid dependency, like in Cryon. So this MRI of a MOG patient shows the long lesions and enhancement of the optic nerve extending more than 50%, and also involvement of the anterior optic nerve pathway, isolated involvement of the chiasm, and also bilateral optic nerve enhancement. And brain lesions, again, in MOG, you get multiple different types of brain lesions like ADEM, deep gray matter lesions, tumor-factive brain lesions like in tumor-factive MS, and leptomeningeal enhancement because it's an encephalitic illness sometimes, infratentorial lesions, and cerebrocortical encephalitis and leukodystrophy-like features. So there are multiple brain lesions that can occur with these patients. And again, the OCT can be used in these patients to make a diagnosis of optic neuritis. Initial thickening later on when the edema settles, and there will be thinning on a long-term basis. However, the visual recovery compared to MOG, compared to aquaporin 4 and MS, the visual recovery in MOG is much better. So this is a 24-year-old man that we saw recently with a history of subacute painless visual loss bilaterally. Recovery was spontaneous. A month later, he developed left hand numbness and painful spasms, left facial twitching, unsteadiness, dysarthria, mood swings, and seizures, without seizures. And the MRI showed some lesions in the brain, as you can see in the brain stem and some cerebellar and temporal lobes. And it was reported as immune or limbic encephalitis, autoimmune encephalitis. And some periventricular lesions were also there. So initial bilateral optic neuritis, followed by unsteadiness, hemiparesis, mood swings, and interestingly, the oligoclonal bands were positive with an index of more than 0.7, a CSF IgG index. So because of that, MS was considered and treated with interferon. The patient got worse with the treatment for MS, and later MOG positivity excluded MS, and he was accordingly treated and made a full recovery. Right, now going into our collaboration with Mayo Clinic in the US, which we started in 2013, 10 years, with the neuroimmunology department at Mayo Clinic, looking at seroprevalence, clinical phenotypes, and outcomes of aquaporin 4 and MOG associated disorders in a consecutive cohort of Sri Lankan patients. So between 2013 to 2023, so all patients with CNS IDDs, multiple sclerosis, NMOSD, optic neuritis, transverse myelitis, ADEM, NDEM, and Cryon, all these patients were actually tested. All samples are tested at the neuroimmunology lab at Mayo Clinic, Rochester, Minnesota in the US. Patient serum samples are tested for both aquaporin 4 and MOG IgG. And the clinical data of the patients was stored at the Department of Neurology at the National Hospital. So annually, we were actually visiting there. There was a short break for COVID, but other than for that, regularly we were updating ourselves and visiting and going through the study with Mayo. And this picture, you can see the pioneering team who discovered the antibody in 2004, including Professor Sean Pittock and Brian Weinschenk and so on. So this is the last time we met this year, at the beginning of this year. So this has been a regular thing that we've been doing for the last several years, following up this work. So we have sent these blood samples directly. We usually collect about 16 ml of blood into two different types of bottles, red top and a yellow top. And the red top is centrifuge, 2,500 to 3,000 RPM. And we take the upper portion of it and split it into 3 tubes and then store it in the freezer. And we send in batches of 27. Over the years, we have sent 2,164 patient samples to the US. And each, actually the cost involved is about $400 per patient. It comes close to $1 million. But all that was borne by Mayo Clinic over this 10-year period. So Mayo Clinic, as you know, is a top center in the world for both research and treatment of all kinds of diseases, not only neurology. So we were very lucky to get this collaboration with them. So we, as I said, tested about 2,164 patients. 239 of them turned out to be MOG positive, which was a large cohort of MOG, one of the biggest in the world. And some of them were aquaporin 4 positive. And some satisfied the NMOSD criteria without both antibodies. And some had cryon and so on. So based on these findings, we retrospectively analyzed data from the consecutive cohort of patients, and we published this data recently. And so in optic neuritis, we found 998 of our patients had optic neuritis, falling into all these different categories, MS, aquaporin 4, MOGADs, and cryon, and NMOSD without optic neuritis. And some of them had single episode optic neuritis without any definite underlying condition. So this is kind of a breakdown of the patients. So about 18% of our optic neuritis patients, that's almost 1/5 of them, had MOG antibody positivity. And MS a little less than that. But large number of them, we couldn't determine the actual underlying cause. In comparison with a similar study over 18 years at Olmsted County in Minnesota, you can see the comparison there. Of course, the difference is that in them, the MS has a very high percentage as opposed to us. But in our case, like we, about 1/5 or 1/4 of our patients having either aquaporin 4 or NMOSD, MOG. So with that, we have calculated a very crude incidence of 1.7 cases per 100,000 population per year. However, there are a lot of limitations here. There's only hospital data. Optic neuritis with secondary causes not included here, and so on. So the dedicated epidemiological study on patients with optic neuritis is currently underway. So coming into each segment of these cases, like this is a 28-year-old female at the age of 19 years, presented with left optic neuritis with 2 further episodes and brainstem syndrome. So MRI looks like MS, as you can see, multiple lesions. And later on, she was found to be having the antibody. And initial treatment with MS-DMTs obviously made her worse. So a correct diagnosis is vital in these cases. Similarly, in this case, a 21-year-old female at the age of 11 presented with left optic neuritis, 2 further episodes, ADEM in 2014, and MOG antibody was again positive in this patient. But finally, although it was a late presentation, visual outcomes are good. So there are brain lesions, spinal lesions as well. So based on these findings, we came up with this seminal paper in the NEJM, in the JNNP, it's a BMJ group publication in neurology, is one of the main journals. So on seroprevalence and clinical phenotypes of MOG IgG associated disorders in Sri Lanka, and we found that about 17.4% of our patients tested positive for MOG, and it was even higher for the pediatric patients. So this paper has been cited multiple times over the years, last few years, and also it is cited in the latest criteria that they have developed for MOG-associated disorders. The MOG criteria, the 2023 criteria, also, as you can see, it cites this paper. So it was a very important paper that we produced, and with multiple citations as well. So isolated optic neuritis is the commonest presentation in MOGADs in Sri Lanka, followed by transverse myelitis and ADEM. So applying the current criteria, the 2023 criteria, MOGADs are diagnosed after exclusion of infectious and granulomatous and neoplastic etiologies. So this basically shows that. And the gender distribution of these patients, they are basically male, female. There's very little to show, like there's female preponderance strikingly less than aquaporin 4 or MS. So the results we got when compared with similar studies in Australia, India, and Oxford are pretty much the same with regards to age at onset. So our patients' average age of onset was in the mid-20s. So optic neuritis, as I said, is the commonest presentation in MOGADs. So we had nearly 240 patients who were positive for MOG IgG. So 67% of patients who have optic neuritis at initial presentation, at some point nearly 72% will have optic neuritis. So some of them had delayed VEPs without obvious optic neuritis. So 3 out of 4 patients with MOGAD had clinical or subclinical optic neuropathy at some point of the illness. So half of the patients had isolated optic neuritis, and one half either single episode or recurrent optic neuritis. Some had bilateral optic neuritis. Optic neuritis is known to be the presenting symptom in 55% of these patients with MOGAD. So mostly a single episode, bilateral. Research was performed on patients with MOGAD. We did some, it was like a pilot study of OCT. 2 groups, namely clinically definite MS patients and MOGAD patients. Those with at least one prior attack of optic neuritis were tested with OCT, performed at the National Eye Hospital. Total of 22 patients were tested there. The average retinal nerve fiber layer thickness was marginally lower in MOGADs than MS, according to this study. Combined ganglionic cell layer, inner plexiform layer was similar in both groups. Temporal quadrant of the optic nerve head was affected more than the superior and inferior quadrants in MS patients. So the similar studies carried out elsewhere have similar results. Asymptomatic abnormalities in the inter-attack OCT is more common in patients with MOGADs than aquaporin 4. So the visual outcomes in CNS demyelinating disorders, now for MS we use assessment called Expanded Disability System Score. Each functional system has a score. For the vision, we have functional system FSS score. FSS is a composite measure of vision of both eyes. Acuity assessment, 20/20 feet measurements, which of course has to be converted to metric, as you can see in here. Normal vision gets a score of 0. Worst vision is disabling visual impairment, bilateral eyes, score of 6. So patients have been followed up for a median of 3 years, MOGAD patients. So about 33% had completely normal vision. Only a small number, about 8%, had disabling visual impairment in the MOGAD cohort. 58% had normal vision at the last follow-up. So in summary, about MOGADs, accounts for about 1/6 of Sri Lankan patients with CNS IDDs. Most common MOGAD phenotype in Sri Lanka was optic neuritis. So with aquaporin 4, so similar patient case of a female presenting with right hemiparesis followed by intractable vomiting, dysarthria associated with bilateral visual loss, bilateral hemianopia, and brainstem syndrome. So this patient was found to be seropositive for aquaporin 4, and she was plexed and made a good recovery. So you can see the brainstem lesion as well as the long lesion in the spinal cord in the cervical and thoracic region. So patients with aquaporin 4 also, we published these data in the Multiple Sclerosis and Related Disorders journal. And we had at the time about 73 positives with aquaporin 4 tested at Mayo Clinic, which was about 4.5% of our cohort. So the estimated prevalence in Sri Lanka, these are crude prevalence of course, is about 2.3 per 100,000 population, as opposed to 3.5 in the Orient, Japanese, Chinese, and Koreans. But it is more or less like what we see in India and South Asia. And the sex distribution, obviously, in this case, a large number of females were affected. Nearly 90% of the patients were females, as opposed to MOG, which is somewhat similar, male-female ratio. So excellent mobility outcomes were seen in these patients. However, the visual outcomes were somewhat bad compared to MOG. The mobility outcomes perhaps was good because most of these patients were treated very early with PLEX. So the diagnosis now is made with, as I said, the 2015 criteria for aquaporin 4 and MOG. And to date, we have about 82 patients who are aquaporin 4 positive. So out of these patients, 44% had optic neuritis at the initial presentation, 59% had optic neuritis at some point of the illness. Subclinical optic neuropathy is rare in NMOSD as opposed to MS. So 1 in 3 patients had isolated optic neuritis in aquaporin 4. 1 in 5 had either single or recurrent episode of optic neuritis. So of the patients with isolated optic neuritis, that is without any long lesion myelitis, about 39% had brain lesions. So it is important to, again, to emphasize the fact that if the patient presents to you only with optic neuritis, a thorough neurological evaluation is almost always necessary. So they were followed up for a median of 8.5 years, these patients. And the FSS ranges from 3.3 onwards. So the visual outcomes compared to MOG is relatively worse here. So as I said, it has a high female to male ratio. The onset in our group for optic neuritis was about 34 years. So in multiple sclerosis, these patients, we have over nearly 300 in our cohort. 39-year-old female presenting with backache, dysesthesia, followed by paraparesis over 2 weeks, history painful visual impairment. So serology was negative, OCB positive, so this is a fairly straightforward case of MS. So the first MS case we reported more than 20 years ago in Sri Lanka, in the Ceylon Medical Journal at the time. And the cohort of MS patients in our registry now, we reported this, published this in the MS-related journal, disorders journal. So MS represents about 1/6 of our patients in the cohort. Commonest presentation in MS also was optic neuritis, followed by cortical syndromes. So all these patients satisfied the 2017 revised McDonald criteria. To date, there are over 260 patients in the cohort. So multiple sclerosis again, optic neuritis is the commonest presenting symptom. So in total, 4 out of 5 patients with MS had clinical or subclinical optic neuropathy at some time during their illness. So interestingly, in MS, at some point, they will definitely get optic neuritis. Even if you don't get clinical optic neuritis, they say even at autopsy, the nerve will be involved. So optic nerve is almost always involved in MS. So some patients with primary progressive MS had less optic neuritis as we expect. So the OCB positivity in Sri Lanka is around 50%. We do the IEF method because we don't do it here. We send it to India and do it. But compared to the Western countries, which is about 80 to 90% positive, we have a lower positivity rate. Perhaps the regional variation or the testing method, perhaps. So these patients were also followed for 6 years plus, and the visual outcomes, as you can see here, the mean score, FSS score is 1.14. So it's better than for aquaporin 4. So 62% of our MS patients with optic neuritis had normal vision. So the visual outcomes of our optic neuritis patients with MS is good. So overall outcomes are good. That could be due to the location of the country and lower oligoclonal band positivity. So it represents about 15% of all IDDs in Sri Lanka, MS. And moving on to CRYON, which is this patient had 3 episodes of optic neuritis, same side, between 2020-2022, incomplete recovery, 0 negative for both antibodies, oligoclonal bands negative, and there's no brain lesion, but the spinal cord also there's no lesion, but the optic nerves show involvement. So CRYON is a situation where you get chronic relapsing inflammatory optic neuritis characterized by steroid dependency, recurring, but there's no evidence for any other condition. So there are 5 diagnostic criteria which are given for CRYON. History of optic neuritis, symptoms with more than 1 episode of recurrence, clinical evidence of visual function loss, negative serology for MOG and aquaporin 4, brain and orbital MRI contrast showing enhancement of optic nerves but no brain lesions, and the response to treatment. Steroid dependence and progression of visual impairment are characteristic in these patients. And if there is recurrent optic neuritis with spontaneous or correction with steroids without any visual disability long term, that entity is called RION. So we had about 27 patients who satisfied these criteria in the cohort, and out of them, 13 of them had bilateral involvement, 4 sequentially, 9 simultaneously. So all had MR imaging involvement. All were treated with IV methylprednisolone pulses followed by Plex in 6 patients and rituximab in 4. So they generally had a good visual outcome, and a large number of them had a FSS of 0, 3 or less. So in CRION patients, generally the visual outcomes are relatively better. They are steroid dependent, and this is preventable visual loss. And then to NMOSDs who do not have the antibodies, because the NMOSD can have aquaporin 4, can have MOG, or no antibodies. So seronegative. We had about 28 patients who are double seronegative but satisfies the NMOSD criteria. So 11 of them had bilateral optic neuritis. 4 had sequential episodes. So in these patients who are seronegative, we found that some of them had, one had oligoclonal bands positivity, and they had recurrences, recurrent optic neuritis in spite of treatment. However, in these cases, we did not see the antibody, and all were treated with methylprednisolone pulses followed by plasma exchange. So they had a relatively good visual outcome. So plasma exchange is an important treatment method in these patients, and in our unit we use plasma exchange very early in all these patients, and we can see in this case there's clear evidence to show that in this case of bilateral optic neuritis, early plasma exchange, even for unilateral optic neuritis without any neurology, early plasma exchange can be vision saving. So we have used plasma exchange for all these indications, and with good results most of the time. At least 60 to 70% of our patients have shown visual improvement. FSS can move from 4.4 to 3.3. So this shows the improvement seen with plasma exchange. The red dots and the green dots are improvements. So in summary, so this gives you a summary of all these different conditions of CNS inflammation, inflammatory CNS disorders, MS, aquaporin 4, MOGAD, seronegative NMOSD, and CRION, and the results of our evaluation. And so optic neuritis seems to be a very common presentation in all these conditions. So it is important to separate them out as much as possible, and to treat them. Initial treatment may be the same, but to ensure that proper diagnosis is made and treatment is done accordingly. So these are some of my references. Then of course I would like to thank a few people. So these are all my research assistants over the years who have worked for me in the unit, and without whom it would have been difficult to achieve these things. So all this work was possible due to the untiring efforts of my young, energetic research assistants over the years. They meticulously maintained all records, registries, blood sampling, dispatching samples to the US, FedEx, annually updating and maintaining clearance from the Ministry of Health, NMRA, Customs, and liaising with FedEx couriers and Mayo Clinic labs to get the tubes on time, then dry eyes on time, and so on. So a lot of work. So they did. So I would like to thank them, Takshan, Kenneth, Shobai, Pasindu, Sandun, Tarusha, Anupama, Yasit, and now Madhya, who's working for me right now. So she's somewhere in the audience. So thank you so much for all this. So then, of course, my medical staff who conducted the MS clinic and with such dedication, helping thousands of young patients, because these patients are young people who are affected with these diseases. Dr. Elahi, I'm happy to see you in the audience. And Dr. Rasika, who has been a live wire in the clinic for many years, over 6 years, until she left to Australia a few days ago. And of course, Dr. Maithili Aravindan, my long-standing, loyal, efficient and brilliant young junior, who's made a huge contribution to all this work over the years. So I would like to thank Maithili. She's been my co-researcher and co-author in all these main papers. So I'm sure she will continue to do this work in the future. So for the scientific advancement of these conditions and patients' benefit, of course. So thank you so much, Maithili. Then, of course, we started this Sri Lanka Committee for Treatment and Research in Multiple Sclerosis and Related Disorders in 2019, along with my colleagues Arjuna, Tashi, Tiva, and Harsha. Happy to see you all here. And this was a good achievement because I think this was modeled after similar regional and local such committees, ACTRIMS, PACTRIMS, ECTRIMS, and so on. So annually we have our Congress here, and we have a collaboration with the European Charcot Foundation. So annual Congress is held. And your members, the College of Ophthalmologists, have contributed a lot. They have given talks, and we have worked together with the ophthalmologists in this field. Right, so now I must thank my family for tolerating me, understanding and supporting me throughout the years. My wife Nilanti, Shamindri, Sayuri, and Charini. And my parents. I'm so incredibly lucky to have my father today in the audience. He's been such an inspirational figure in my life. Also to my late mother, who passed away just a few years ago, taking so much trouble to care for us and raise us to what we are today. I am indebted to both my parents. And finally, to my beloved teacher, guru and mentor in neurology, Dr. Jagat Vijayasekara, senior consultant neurologist. Under his guidance and supervision, I learned not only neurology, but also how to inspire and encourage, motivate a whole new generation of young neurologists. And I see some of them in the audience. I'm so happy to see them. So thank you very much, sir, for all what you did. Thank you. Thank you so much.
Thank you and congratulations, sir, for that outstanding oration. We were enlightened by your excellent description on a very important topic. We were privileged to have you here today, and your contributions for the development of the field of neurology in Sri Lanka is highly appreciated. I now invite Dr. Kapila Bangatilaka, President of the College of Ophthalmologists of Sri Lanka, to award the Certificate of Appreciation and souvenir to Dr. Vimsara Senanayaka, Consultant Neurologist. Thank you, sir.